I think we can ease into the webinar. Good afternoon again, everyone, and thank you for joining us for the last webinar that we have for 2025. And I'm delighted to introduce Professor Jan Paul Heisig today, our speaker. Jan Paul is the head of the research group Health and Social Inequality at the Witzebe Social Science Center in Berlin. And he's also professor of sociology at the Freie Universitat in Berlin. He's principal investigator at the Einstein Center for Population Diversity, and his research focuses on a broad span of topics from social inequalities in health and education in labor market to quantitative methods in sociology. So we're very happy to have him here with us today. I now hand over to Jan. Thank you.
Yes, thank you so much, Vincent, for the introduction, and thanks for the invitation to the seminar. I'm really looking forward to presenting this project here today. As I said, before we started, I was talking to Vincent a little bit about the project. It's actually been a few years since we collected the data, but we haven't really had the chance to write this up. Now we're finally in the process of doing so. So all of your comments and questions kind of will be of particular interest to me, as I can incorporate them in the draft that I'm currently working on. Okay, good. So what's the project about? The title is Ethnic and Social Inequalities and Access to Healthcare, Evidence from a Nationwide Field Experiment in Germany. And that kind of says, what it is about. It's what we did. We conducted a field experiment, but, I guess kind of experiment most of you are familiar with. But I say more about that in a minute. Looking at access to healthcare in the German outpatient care setting. And let me start, because the main focus of the talk will really be on the results of the experiment and the empirics of it. But let me start with a little bit of background. So starting point of our project was the fact that, qualitative studies and survey measures of, perceived discrimination suggest that the latter is widespread in healthcare settings. But perhaps somewhat surprisingly, field experimental evidence, which is often considered the gold standard for measuring discrimination, remains surprisingly scarce in the healthcare setting, whereas, as again, I think many of you will know, there have been quite a lot of field experiments looking at discrimination, for example, in labor market settings, housing market settings, etc. There are a few exceptions, which I'm listing here, but many of these studies are actually very, very small in terms of sample size, or have a very narrow geographic focus. Being, for example, the Kugelmesh study is just focused on New York City in the United States, and kind of covers a few hundred cases or so. So kind of one key kind of feature of our experiment in that regard is that the sample is much larger, which also enables us to look at interactions, at effect heterogeneity in various ways. And we really cover not only a specific town or region, but the whole of Germany. So basically what we did here is, to make this a little more concrete, we sent almost 7,000 appointment requests to private practices, which are the main providers of outpatient care in the German context. And these were private practices all over Germany. So we're really covering the whole country, and can also compare urban and rural areas or so, although these are some analysis, as we'll say later, that we still need to conduct. Okay, so how do we do this? Well, we basically did it by email. We initially also tried to contact practices by phone, but for reasons that I'm happy to elaborate on in the Q&A, that turned out not to be practical. So we ended up contacting practices by email, and we basically sent all of these 7,000 practices more or less identical emails written in error-free German, but randomly varying a few features of these requests to investigate whether the responses we got were dependent on these features. And what were these features? The first thing we varied was the name, which was shown, sorry for showing the German text here, but kind of the key information for you is kind of on the right-hand side of the slide, because these were the things that we varied. The first thing was the name, which indicated the gender and the ethnic background of the patient sending this request. So it was either a typically German, a typically Turkish, or a typically a Nigerian name. We also included an additional gender cue in the email text, basically because we were a little bit worried that some of the non-German names might not be recognized as either female or male. So we included this additional cue, basically, kind of using the fact that, you have unambiguously a feminine and masculine form of the word patient in German. We also mentioned a specific condition that was the reason for sending this request. Then we also mentioned a specific insurer, and we're particularly interested, as I will discuss in a little more detail in a second, about whether mentioning a private or a public/statutory insurance made a difference for the response probability and the content of the response. And then finally, we mentioned the name, which was kind of also contained in the email address. We mentioned the name, obviously, at the end, and sometimes included a doctoral title as an indicator of a high level of education or high social status, because we felt, of course, only a small portion of the German population has a doctoral degree, but it kind of felt as the one cue, because it's common to mention it in this type of communication that could be naturally included in this kind of request, right? People would not mention their school degree, for example, or that they had another kind of higher education degree, but mentioning a doctoral degree in the signature of an email is quite common, actually. So we either included it or not. This example shows one where it was not included, right? So this person did not mention a doctoral degree. Okay, so before we get to the results, let me also contextualize this a bit by saying a few words about the German healthcare system. First of all, and particularly the system for outpatient care, right? Not inpatient, longer-term hospital-based care, but for outpatient care. It's a very decentralized system by international standards, where private physician-owned practices are the primary providers of outpatient care. And these are also the kinds of practices that we approach. There's also more or less free access to specialists, meaning that unlike in many other systems, there's no gatekeeping by general practitioners when it comes to accessing, for example, a dermatologist or some other kind of specialist, medical specialist. So, which also means that we did not only include GPs in our study, but also a few kind of specialists. Particularly, specifically, we included psychotherapists, dermatologists, and radiologists. Radiologists are a bit of an exception in the sense that you need a transferal to access them, but that's why we mentioned in the kind of email that I just showed such a referral when approaching radiologists. And then, as I already hinted at, health insurance is mandatory, and it is two-tiered, with the first tier being the statutory health insurance, which is mandatory for regular employees, wage and salary workers with annual earnings, below a certain limit, which in 2023 was approximately 66,000 euros. And then wage and salary workers earning above this threshold, as well as the self-employed and certain other groups of workers, most importantly civil servants, they can get insured with private health insurance companies instead. And the most important thing, complicated system, so within both tiers, there's multiple companies or insurers offering their services. But for our purposes, probably the most important fact is that private health insurance reimbursement rates tend to exceed those of statutory health insurance by a substantial margin. So from the physician's perspective, at least to the extent that physicians are interested in making money, privately insured patients tend to be more attractive than statutorily insured patients. On top of that, Also, because of this earnings caps, civil servants also tend to be more highly educated than, the average worker in the German economy. Private health insurance might also be read as another marker of high social status, high income, high levels of education. But in addition to that, and probably the more important fact is that the reimbursement rates tend to be a lot higher. And there's lots of anecdotal, a little bit of experimental, but lots of anecdotal evidence that actually privately insured patients receive preferential treatment in the German healthcare system, both in outpatient and inpatient care, but we're looking at the outpatient one and, kind of doing one of the largest study yet to look at this. Okay, so what are the research questions we are kind of trying to answer with that experiment? Very straightforward. The first one is there discrimination in access to healthcare based on ethnicity? As I said before, indicated in our experiment through the use of typically German, typically Turkish, typically Nigerian names. Is there discrimination by insurance status? And there the contrast is between, as I just elaborated, privately and statutorily insured patients. We included that in the experiment by mentioning a concrete insurer in this request that we sent. Is there also discrimination based on social status or a level of education? As I've said before, the indicator we used for that was the doctorate degree, and also by sex gender, which we covered by including male or female sounding names. And then kind of, assuming that we find discrimination based on ethnic background, a kind of secondary question, and there, our large sample size really starts to matter, is we're kind of asking whether minority patients can overcome discrimination through positive signals, meaning, more technically phrased, is there a positive interaction between Turkish or Nigerian ethnicity and private health insurance or a doctorate degree as kind of markers of high social status or, generally patient attractiveness? Of course, this is kind of predicated on the assumption, spoiler alert, which we do find, that there's ethnic discrimination in the first place, but we'll see that in more detail in a second. Okay, good. So these are the research questions. Before we get to the results, let me say a few more words about the implementation of this experiment. It was pre-registered and approved by the WZB's Institutional Review Board. Conducted it with almost 7,000, so more precisely, a little over 6,700 practices in 5, kind of domains or specialties: GPs, pediatricians, radiologists, dermatologists, and psychotherapists. And we only send one request per practice. So it's a between design, which is not ideal from a statistical power perspective, but we kind of traded this off against, ethical considerations. First of all, it means that, there's no way to kind of try and assess whether an individual practice, because these practices were obviously included in the study without, providing any form of consent, but there's no way to identify discrimination on the individual practice level because we only send one request per practice. And of course, it also means that, the additional the burden introduced by running our experiment for each individual practice was minimized, right? So these were kind of the ethical considerations that, despite its drawbacks in terms of statistical power, led us to adopt a between design. The data collection took place in 2 waves. The first in the summer of 22, where we did not include GPs, for another kind of ethical reason. This was kind of was still a time when the COVID pandemic, especially during those months, was going quite strong in Germany and basically, increasing demand, the patient burden on GP practices during that time. And then we ran to kind of, complete the survey. We ran a second wave in January 23 when, basically COVID was no longer an issue. And all of the analyses I'll be showing control for date and time of the request, but it also means that, when it comes to the day of requests, the data are not perfectly balanced between the different specialties, obviously. Okay, patient characteristics I already mentioned. I'm gonna talk about all of them except for the urgency of the condition, which is another thing we kind of manipulated. And the main outcomes that's important are, first of all, whether received a positive response, meaning that the practice indicated a general willingness to accept the patient. Our request actually asked for, asked the practice, to offer a concrete appointment right away. And that's exactly our secondary outcome, whether our fictitious patients were offered an appointment right away. And some of the effects are general, as you would imagine, the positive response rate tends to be higher than the appointment offer rate. So many practices would respond, yes, of course, we would be happy to accept you, but can you please call during business hours to schedule an appointment? So that would be the typical response that would be coded as a positive response because the basic willingness was there, but no concrete appointment was offered yet. But we're looking at both kinds of outcomes, and I will also do it in the paper, and I'll also do that in the presentation. Okay, with that, let me come to the results. So this just shows you the overall appointment offer and positive response rates. So in approximately 46% of cases, we received the kind of positive response that I just described. Often we would receive no response, and sometimes we would receive a response basically saying, so we're not accepting new patients. So these would not qualify as positive responses, obviously. So say, but in 46% of cases, approximately, we received a positive response, and we were offered a concrete appointment in about 17% of cases. So as I said, appointment offer rate is much lower. I should also say that, whenever we received either of the two, positive response or appointment offered, we also, responded to these emails, usually within 24 hours, and basically said, no, thanks, we no longer need an appointment. We found someone else, in order not to block services for any real patients there. Okay, so appointment offer rates are a lot lower, makes sense. Will become kind of important or interesting later on as you follow the results, because you can kind of see that certain types of patients seem to be a lot more attractive to practices than other types of patients. And these attractive kind of patients, they are much more likely to be offered an appointment right away, right? Like the privately insured people, for example. Okay, turning to ethnic discrimination. This shows basically percentage point differences controlling for lots of things. I mean, all of this is fully randomized, so but we nevertheless control for other stuff to kind of increase precision a bit. And as you typically do in these kinds of studies, and you can see that the positive response rates for Turkish and Nigerian patients relative to the reference group of German name patients was lower by 6 to 7 percentage points. We actually hypothesized in our pre-registration that the penalty, well, we hypothesized that there would be such a penalty for signaling non-majority ethnicity. We actually suspected the penalty to be larger for Nigerian name patients than for Turkish ones, because Turkish origin immigrants and their descendants are simply much more present in larger group in the German context than Nigeria. We do not really find any evidence of this in the data, also not in the other outcomes, as you can see here. Find a similar effect in terms of the direction, also in terms of statistical significance for appointment offers. In absolute terms, the difference is smaller, but relative to the much lower baseline rate, in relative terms, these effects are actually even larger, right? Kind of depends on your perspective. But qualitatively, well, they clearly go in the same direction and are highly significant. I mean, maybe we can discuss effect sizes a little bit at the end. So 7 percentage points a lot or not. I'll come back to this at the end. We do not find any discrimination, both, very, very small effect sizes that are also statistically insignificant based on gender, whether we used a male sounding or female sounding name in the appointment request. We find strong positive discrimination, kind of as expected, and in line with the anecdotal evidence I mentioned for private versus statutory insurance. And here it again shows, even more clearly than in the ethnic case, again, recall the much lower baseline rate, that the effects are, and the same also holds for doctoral title. So as another, sorry, got a little confused here, presentation myself. So this is private insurance and doctoral title, positive effects, both things, and they are almost as large, or well, in the case of doctoral title, just as large for the appointment offer rate as they are for the positive response rate. Again, relative to a much lower baseline, really indicating that privately insured patients and patients with the doctoral title are considered as, well, highly attractive groups of patients by the average practice, I would say. Okay, so these were kind of the average effects for our focal experimental treatments. Now let me say a few words about the second research question, which, as you may remember, was, are these markers of high socioeconomic or social status, are private insurance and status and doctoral title helpful in overcoming ethnic discrimination? And standard theories of statistical discrimination, one would probably say, which is why this was also the hypothesis that we pre-registered, they would say, yes, they should be helpful, right? So minority ethnicity name might be interpreted as an indicator of perhaps lower social status or of limited communication skills that might complicate doctor-patient interactions and so on and so on. But if that is the case, then at least simple statistical discrimination theory would suggest if you then additionally provide indication of high social status, this should be helpful in kind of counteracting these stereotypes about patients with non-majority names, and in this sense, should carry greater returns than they do for patients with German-sounding names. So what do we find in that regard? So this shows you the positive response rates by ethnicity for patients with statutory health insurance, right? And this is kind of so this shows you the effect of mentioning private instead for German name patients. So the difference is approximately 9 percentage points. And this is the effect of having private instead of statutory for Turkish and Nigerian name patients. And as you can see, contrary to what we expected and contrary to what a simple statistical discrimination argument would suggest, the returns to mentioning private insurance rather than statutory tend to be smaller for patients with non-majority ethnicity, as indicated by the name. And the picture is the same for appointments, right? So that was positive response. Now we're looking at appointments. Again, the effect of health insurance status. And it's also qualitatively the same, so very consistent, although not all of the relevant interaction effects. I brought the p-values in the backup slides, I think. Not all of these contrasts in terms of really looking at the interaction are statistically significant, but some of them are, and in general, the picture is very consistent in the sense that we also find here that both for positive response and appointment offer rates, the returns to mentioning a doctorate degree tend to be smaller for those using a non-German name than they are for German name patients. Again, contrary to what we expected and to what simple statistical discrimination accounts would suggest. So it rather seems to be the case that these positive status signals, and we can only speculate about the explanations for that, but it seems to be the case that they are discounted rather for minority ethnicity patients rather than helping them overcome the ethnic discrimination that they are facing. Let me say a few words about effect heterogeneity. So as I said, one strength of our experiment is simply the much larger sample size than in most previous studies, and then also the broad geographical coverage. So that allows us to look at effect heterogeneity in various ways. The first is, I have a slide on that, I think, yes, so that's why I skip it. You can find some suggestive differences across specialties. We also find that's kind of one information we have about practices, quite interestingly, that practices offering, of course, that was not experimentally assigned, right? So now it's really observational differences between practices, but we find that practices offering communication in Turkish actually strongly favor Turkish patients, where there's no clear differences by physician migration background as proxied by the name of the physician kind of leading the practice. Of course, another question that we can discuss in the Q&A is, I mean, typically was not the physicians themselves, of course, that responded to the request, was rather the practice staff, but kind of our auxiliary assumption is that the leading physicians would kind of shape the overall culture and attitudes, through selective recruitment, etc., and setting norms and standards in their practice. We also find no clear interactions between patient minority ethnicity and online doctor ratings, which is another thing we looked at. So maybe that is good news if you take these as a probably noisy measure of physician quality or so. It's not like the higher rated, so supposedly higher quality physicians would be more strongly discriminating. And then we also looked at how the propensity to discriminate is related to local right-wing vote shares in the most recent federal election, but we also don't find any clear heterogeneity in that dimension. Okay, few things we still want to test. Happy to elaborate on that in the Q&A. Maybe few, just to show you a little, some of the results for differences across specialties. I mean, not all of these were equally sized simply because there aren't so many radiologists. That's kind of a smaller group, much larger confidence intervals. And in general, I mean, I would treat these as suggestive differences because, well, again, simply, many of the comparisons are not particularly well powered, but one kind of more or less consistent pattern emerging from these results. This is positive response rates again, and looking at the effects of mentioning a Turkish rather than German name, a Nigerian rather than German name, private insurance rather than statutory, and so on. One kind of consistent pattern is actually that pediatricians tend to be less discriminating, both on the basis of ethnic background and also markers of social status, which might have to do with the kinds of people that select into these specialties and so on. Yeah, we can only speculate about it, but I think quite an interesting result. Whereas, for example, especially when it comes to ethnicity, there's also some evidence that psychotherapists are discriminating more strongly than most other specialties, perhaps because it is so communication heavy. So we can kind of, there's also some qualitative literature suggesting that among psychotherapists, there's a strong preference for certain types of well-educated, communication proficient types of patients and so on. That's broadly consistent with these results, but I would treat these as very suggestive due to limited sample sizes. Okay, then let me conclude with a few summarizing remarks and some discussion. Overall, our field experiment finds compelling evidence for discrimination based on ethnicity, insurance status, and high social status, as indicated by a doctorate degree in outpatient care in Germany. We find that penalties for patients with Turkish and Nigerian sounding names are broadly similar, again, contrary to what we expected. And we also find that benefits for private insurance and doctoral titles are smaller for patients with foreign sounding names. So rather than, as I said before, having minority patients overcome ethnic discrimination, these kind of signals of high status seem to be discounted and carry smaller benefits for them than for German named patients. And very broadly, based on these results, we would conclude that discrimination in healthcare access likely contributes to social and ethnic inequalities in healthcare utilization and therefore eventually health outcomes. So these were kind of, the substantive insights that more or less directly follow from our experiment. Maybe some, kind of final words, putting, these findings into perspective and differentiating between, two alternative stylized interpretations of the findings. So the more optimistic one, I think, would go as follows. Well, discrimination is meaningful, but not super large, right? I mean, 7 percentage points in the positive response rates relative to a baseline of 46, 47%, is maybe not that much. There's an ample supply of practices in many regions in Germany, not everywhere. So you could argue, well, how bad is it really? People just need to write a few extra emails, make a few extra calls, but everyone will probably, get an appointment sooner or later. And on top of that, you might also argue that our field experiment was kind of not reflective of how people actually get access to healthcare, because we really randomly send requests to practices all over the country, whereas there might be kind of knowledge, especially within, for example, immigrant communities, about which doctors to approach, which ones are accepting and tend to take minority patients seriously, and so on and so on. So it's not actually like people would have to randomly send emails to practices all over the country. They might know, from social context or so, which practices to approach and which practices they might have, good chances of securing an appointment and receiving quality care with. So that would all be arguments for an optimistic interpretation. But we think there's also possible pessimistic interpretation. First of all, several kind of variants of it. First of all, you might be worried about, regions which also exist with few practices, and especially few specialist practices where patients might not have the freedom to choose between alternative providers or to contact several, simply because there's just very few or only one specialist close by. Delayed care, due to not being able to secure an appointment as easily, might have severe consequences in some situations. And you might also see the initial contact that we looked at in this experiment is only the tip of the iceberg, right? And you might take the results as an indication that ethnic and status-based discrimination exists in the healthcare system. And that might make you worry about later and more consequential stages of the healthcare process. What does the quality of doctor-patient interactions look like, right? How seriously is the patient taken? How thoroughly is their case considered, and so on? So you would think that these are, later stages of the healthcare process that are potentially or likely to be much more consequential for patient outcomes. And the fact that we find, discrimination in the initial step might suggest that discrimination, although much more difficult to demonstrate, compellingly using a field experimental approach, but it might, kind of shift your priors and make you think that this kind of discrimination is likely to occur also in later stages in the healthcare process. That could be a lot more consequential for patient outcomes eventually. Okay, with that, I would finish the presentation. I'm looking forward to your comments and questions.